Hi guys, I'll be talking about the skilled OSCEs today. A short video. It's not short actually. Short description about each skilled OSCE task is what I'm trying to say. Uh, just giving out the simple scenarios and the tips that can be expected out there before I forget all about the exam in a while. I really don't want to remember anything about it. It was like a tough journey for me though. So, anyways, they are skilled 8 OSCEs, and any course that you'll have to take before the exam, you'll have to take one skilled OSCE course because the mannequins are different. You won't get the same mannequins everywhere, so make sure you take the course where they have all the mannequins, and you cannot practice on your mannequin everything about the skilled OSCE. Because you would need the CPR mannequin, the syncope mannequin, and you would also need the subgingival scaling model and the X-ray mannequin and the LA mannequin. So you can practice pattern fissure and rubber dam by yourself on your mannequin. That's all right. So the courses are expensive. Of course, some of them charge up to $1,000 for one day. But you have to take one, otherwise you won't get a hang of how the exam works exactly. But the most important things in the skilled OSCE is that somebody is constantly observing you. So you have to be very confident of what you're doing and not get conscious about the examiner being present right next to you. So how the setup is in the skilled OSCE day, so uh, the exam batch is divided into two parts. One part goes for the technical, the other goes for the skilled OSCE, and that skilled OSCE session is for 3 hours. All the details would be given on your badge with the timings in which room you have to be, and make sure that you finish your task in the specified time. You cannot extend it, and so be very very conscious of the timing. For example, if you're doing a pit and fisher task and you just don't look at the time and you're so busy doing your task that the bell has rung and the 10 minutes are over, you have to leave the room. So in that scenario you won't be able to even close the light and upright the patient chair or do your infection control after your task is done. So that can lead you to reduce your marks in the exam. So be very conscious of the time of which you're doing, and for that you need to practice. Only one day of skilled OSCE practice is not sufficient, so I would suggest that for rubber dam, for pit and fissure, for subgingival scaling, you practice at least 3 days in advance before your exam, and make sure you do each skilled OSCE at least 5 times before your exam. So I practiced rubber dam at least 3 days continuously, and I was fine with it because I wanted to finish in less than 9 minutes. And make sure you know all the scenarios which are related to the exam so you don't get nervous and stressed and anxious about it. So let's start with the LA task. So in the LA task, what are the scenarios that can be given to you? They can ask you to give LA on 1-1. So in my exam, I had got the LA task, and they said that there was so and so patient, and he had the trauma, and there was a suspected fracture of the root, and the dentist wanted to do root canal and composite filling for 1-1. So you have to give local anesthesia to 1-1. That's it. That was what written on the screen. Now I read this in like 1 minute and I still had 2 minutes to go. So in those 2 minutes, what I did, I went on the patient chair where the mannequin was kept, and there were three things kept there. There was MEMS, that's the medical directory. There was therapeutic guidelines, and there was the medical history of the patient. And the examiner is standing right at the corner of the room. She's just observing me. Like, though I will be start to getting scored after the bell has rung and my 10 minutes has started, the first 3 minutes I have to utilize very wisely. So I read the question twice, read the tooth number twice. I went and I asked her, can I read the medical history? You have to ask first. You directly don't jump and touch anything. She said, yes, you can. So I took the medical history, and they have written in very tiny fonts, everything. And there is a tick on the right side saying if the patient is allergic or not. So right on the top, it was written adrenaline and allergic tick. So of course, I cannot use local anesthesia with adrenaline. So I need to know what has to be kept there and what I'm supposed to pick up. So what I did the next thing was and the patient was also taking Nardil. Okay, Nardil is a uh, antidepressant, and according to the latest guidelines of therapeutic guidelines, you can administer adrenaline even if the patient is taking Nardil, but you have to pretend to read as to what that is. Assume that you don't know that brand name. So what you will do is you will open your MEMS and you will go to Nardil and check. Now, what are the scenarios that can be given to local anesthesia? Uh, Scenarios that I know of are either you'll get tooth number 11, then you'll get tooth number 16, and a pregnant patient. So you have to open therapeutic guidelines and just go through. And there is a number on the therapeutic guidelines which you can directly jump instead of searching. 282. Why you have to do? You have to show this to the examiner that you are being a responsible clinician and double checking the medical history and checking from therapeutic guidelines and the MEMS. So MEMS you open if only there is a brand name of a drug given that the patient is taking. If there is no mention and the patient is just pregnant, just directly go to therapeutic guidelines, page number 282. Yeah, remember this page number. Just open, pretend to read, close the book and keep, because the examiner is observing you, though she is not marking you, but she is observing what you're doing and are you being a responsible clinician or not. So do not forget to read the medical history, because if you don't and you directly jump and pick up the local anesthesia with adrenaline, for my exam case, you'll fail, right? Because the patient is allergic to adrenaline. So, anyways, so scenario 1, 1 tooth can be asked, 1 6 can be asked, 3 6 can be asked, and 4 6 can be asked, and 3 6 can be asked. So what you need to know is to know the landmarks where you have to give, and that LA mannequin is a very different mannequin. Uh, when you insert a needle, it doesn't leave a mark. You know, when you take it out, it's made up of some different kind of material only. So you should remember the landmarks and how you're going to take the needle and inject, and for how long you're injecting. So once you have read the scenario and still the minutes are left, go to the area where you are supposed to pick up the stuff. See what all is kept and just revise in your mind what all you have to pick up. So when I was at the clean trolley, I saw that there were three different cartridges kept: plain lignocaine, a lignocaine with adrenaline, and citanest. Citanest is phelipresin with prilocaine. So I knew that I'm going to pick up the citanest. I could have also picked up lignocaine, plain one, okay? But I had kind of memorized that for the upper jaw, no matter what the scenario, I'm going to pick up citanest, just to be very, very clear and not make a mistake of accidentally picking up lignocaine with adrenaline. So, because as so far the ADC cases, only in the upper jaw they have given that the patient is allergic to adrenaline. See, ADC is a very scripted exam. They have so far not made major changes in the way they have presented the scenarios. But yeah, they can make a change. So just keep your mind open. But just to ease your process, the upper jaw is often asked that the adrenaline allergy is present. So just pick up citanest. Uh, so there it is. Lower jaw, so far they have not said that the patient is allergic to adrenaline. So you can still pick up lignocaine with adrenaline, like xylocaine is the name out there. So yeah. So upper arch it was, so I just went and picked up citanus. So anyways, I'll come to the picking up part. So I saw what all is kept there. I saw there is this cartridge kept. The cartridge is air filled. There is no liquid in it in the exam. You have to pretend that there is a liquid, okay? Because you cannot put liquid in the mannequin. So the syringe is there, the cartridge is there. Learn how to assemble it, and the needle is kept. Now needle is 27 gauge, 25 gauge, 30 gauge. It was the upper jaw, so I took a short needle of 27 gauge or 30 gauge. Yeah, I took a 30 gauge short needle. For the INB, in case it's asked, you can take a 27 gauge long needle. And there was a needle holder also which was kept there. There was a kidney tray which was also kept. Now, kidney tray is very important there, okay? So now, as I saw that 15 seconds were left, I went and stood next to the sink. And when I had entered the room, I had already kept my eyewear out there. Now, in case you accidentally forget your eyewear, they have kept an extra pair of eyewear, but don't forget, okay? So, all right, so the time started, the bell rang. So immediately the first thing I did was to open the tap and take little water on my hands. Then they take the soap, wash. Again, this is the hand motion. Do like this, do like this, do like this. Waste 40 seconds completely. Wash. One paper towel, close the tap. Three paper towels, dry your hands, throw. Take your eyewear, wear. Sanitize. Now your hands are clean. Go to the clean trolley area. Pick up. Now, since LA was a task where I want to sit and work, and the first 3 minutes itself, I'd adjusted my chair on which I'm going to sit, okay, because she allowed me to do so. So now I'm not bothered about it. I know that I've adjusted my chair, and all I have to do is drag it with my, when I will be sitting with my legs, I'll drag the chair towards the patient chair so that I don't touch with my hands. Be very conscious, do not mess around with the infection control. Like I mentioned in my previous video, a very dear friend had passed everything, but he failed in infection control in the LA task. He also doesn't remember where he flunked, but it is what it is. My own result is expected after 5 days, though. 15th May, I had given the exam, and bang, 20 days ADC results are released. And yesterday, I came to know people who had appeared for 10th of May, their result had released. So mine is the next expected after 5 days, I guess, probably on 5th of June. Whatever happens, happens. So, anyways, let's go back. So once I had cleaned my hand, I went to the clean trolley. I picked up Citanest. Now, when you pick up, pretend to read the expiry. Then I took the cartridge, the syringe, and I put the cartridge properly, okay? And then I took the needle with my hands. I opened the small portion and inserted the needle inside the syringe. I kept that in the kidney tray. I took the needle holder. I also kept that in the kidney tray. Only two things will go in the LA task. Then you are supposed to hold both of them with the kidney tray. Don't just hold the kidney tray because it can fall. It's a long, after assembly, the syringe becomes long. So hold both of it. Come, drop it nicely on the bracket table, very gently and softly, because you don't want anything to roll over and fall. Already on the bracket table, mouth mirror would be kept. Now, once that is done and you're sure you don't need anything else, go and keep saying all these things loudly in your head, okay? So you're very conscious of what you're doing. Forget examiner is there. Just be very conscious of your task. Imagine you're actually performing in your clinic. So then you'll be relaxed and very confident. So then go, again sanitize your hands, wear the gloves. Now the gloves are there, you can't touch the chair on which you're going to sit. So first you'll come on the patient light, recline the patient chair, take the bracket table to the position you want, then sit on your chair and drag it with your legs till the patient chair. Now when you have sat, take the mouth mirror and check the tooth on which you are going to inject, okay? So after you have checked, the light is focused. Now take the syringe from your left hand, take the needle holder and remove the top so the needle gets exposed. Now gently take the syringe on your right hand with your left hand. I'm talking about this as a right-handed person. Reflect the upper lip. Do not use your hands. Take the mouth mirror, reflect the upper lip. And now comes the most important part. When you inject, aspirate. Say, I'm aspirating. Aspirate once, and the cartridge is 2.2 ml or 1.8 ml. For me, 2.2 ml was kept. So take a full good 1 minute to inject on the label aspect. Like literally count. I counted till 50. Like 1, 2, 3, 4. LA is a simple task. It will get done in like 8 minutes or so if you are doing absolutely gently and slowly. So you don't have to rush. There is no need to rush. You have 10 minutes in your hand. So, and anyways, in Malamet, the golden book of local anesthesia, it's mentioned that when you inject LA, it has to be around a minute. You cannot just, like that. So count in your head, 1, 2, 3, 4. You have to pretend because there is no liquid, there is air, so it's kind of funny. But then you have to pretend, and once you see that you have reached like only 0.5 ml is left, withdraw. Again, put in the palatal, aspirate. Again, inject for another 10 seconds or so. Once that is done, just hold the syringe like this. Now, your thumb was in the ring of the cartridge, the syringe, right? Now, you release your thumb and you hold the syringe so that the needle is pointing down. And you take the needle holder, you go to the sharps container, which is kept right next to the sink. Now, you position it such a way that the needle is right in the opening of that sharps container, and with the needle holder you twist and twist and twist, and you drop off the needle there. You take the needle holder which is still in your hand, and you come back to your bracket table, keep it in the kidney tray, go back to the sink, and then you remove that cartridge, and there is another kidney tray like thing kept there. Keep the cartridge here, take the syringe, come back to your bracket table, keep it there. Then upright the patient chair, remove the bracket table, off the light, check everything, go back to the sink, dispose of your gloves, wash your hands, remove your eyewear and keep, sanitize, and then take your eyewear and stand in the corner if time is left. For me, for LA task, almost 1 minute was left when I was done. So this is how you're supposed to go. When you're giving an INB, make sure you palpate the landmark first, and then you inject, aspirate, give. Come to the lingual, again aspirate, inject, remove. For the buccal nerve block, again inject, aspirate, and give. So you are supposed to take proper time. For the INB, make sure that you're coming from the opposite. So if you're giving in the 3-6, your barrel of the syringe is supposed to be on the premolar here, and the opposite. Understood? 1-6 is easy, 1-1 is easy. They are not pretty much landmarks. For 3-6 and 4-6, make sure that the syringe is pointed from the opposite end for the INB block. So yeah, read the question properly, assemble everything, don't be panicked. It's easy. The LA task is actually easy. You'll finish with ease. So that's about the LA task. Then you come about the rubber dam task. Now, rubber dam task scenarios, anterior, they would mention that you are doing a composite filling on 1-1 and 2-1. So you have to isolate at least 2 teeth behind it. So you start isolating from 2-3 to 1-3. You should put your clamp on the premolar up. So in rubber dam task, learn how to quickly punch. So my technique is I assemble everything on the chair table. Now I'm not going to go again and again about the hand hygiene and the infection control protocol. I'll just give you the tips about the tasks. So for me, rubber dam, what I do is I take the sheet. There's this purple sheet which is very thick, and I will punch 2 sheets so that I don't waste time in case one of my sheets is torn. And rubber dam is an important task because you have to do so many things, and you're supposed to finish in just 10 minutes. Actually, you kind of have 8 minutes because the first 2 minutes you are just taking so many materials and keeping. So don't go into that. I'll tell you how to do it. Once you're done with your hand hygiene, you're on the clean trolley, just focus. How many scenarios are there for rubber dam? There are 4. One would be you have to do pit and fissure sealant on the left side. So the teeth number are 3-6, 3-5, 3-4. So you isolate 3-6. You can also isolate 3-7 because it's in pit and fissure, only the occlusal portion is there. So it's okay even if you don't put it on 3-7, but better you do. So 3-7, 3-6, 3-5, 3-4. Then you are doing a root canal on 4-6. So 4-7, 4-6, 4-5 are to be isolated. Then you are doing something on 2-6. So again 2-7, 2-6, 2-5 are isolated. And then anteriors, 1-1, 2-1 you are doing. And so you isolate the entire anterior. And there is a scenario in which they would say that you're doing something on 1-1 and 2-2 is missing. So in that scenario, make sure you're reading everything well because you will not punch on 2-2. Okay. So when you have read the scenario, just the first thing that should come in your head is how many holes am I supposed to punch? So align the sheet well, punch in 2 sheets. It's okay. Take time there. It's fine. Once you have punched, take the clamp. Now clamp for the premolar. So in the upper arch, only the premolar you are supposed to do it. Okay, if it's asked for anterior, if it's posterior, then you will take the molar clamp. How will you remember the clamp numbers? For the upper premolar, it's 208 or 2A. For the molar clamp is 7. Universal is 7. Just remember this. You can use that 7 here, 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 anywhere. And for premolar, it's upper, it's 2A. Now, try the floss to the clamp. Now, because so many people have used that clamp, I've heard candidates say that the clamp has become loose, so it doesn't come properly in the clamp holder. What you do is you press the clamp, like press the clamp properly, the ends, so that it becomes sturdy again. You put a floss, and once you put the floss, you attach that clamp to the sheet right there and there. Once you have done that, keep it on the table and take the frame and attach it right there and there. So the entire assembly is ready. All you have to do is now just take the clamp holder and fit in the tooth. That's all. And if you are able to do in one shot, your life will be so easy. Like now, then all you have to do is just isolate the other teeth and etc. Doing it the other way, meaning you have just attached the sheet on the clamp, then you put the clamp on the tooth, then you are putting the sheet on the frame. It takes a lot of time, but on the table it happens very quickly, and that's what I did. Honestly, I could finish my rubber dam in my practice when I used to do myself in 6 minutes, and it used to be just fine. So try and do in that method if you like. So I assemble everything on the table only. Now once I've done that, all I do is take a clamp holder, the widgets, the yellow one, because I have to put that. Take 3 or 4 of them, take 2, 3 floss, and then come and put it on the table. You have to take the plastic filling instrument also, or if you want a spoon excavator, take a spoon excavator as well. Now there's a liquid rubber dam also kept there. It's like a flowable composite. Just take that also in case accidentally some leakage you see is there. You can just put that. Because they are going to assess if there is a leakage issue or not. Once you have put the rubber dam, they will check if you have inverted the rubber dam properly or not, and you have actually isolated properly or not. So once you have dropped all this on the table, go sanitize your hand, wear gloves, come back. Rubber dam is a task which I like to do in a standing position because it happens more faster. So, but you can do it as per your ease. So now you have. So since my assembly is ready, all I do is just see the tooth on which I'm going to put. I will take my clamp holder and I will put in the clamps and I will directly insert it. Once it's inserted, like 50% of job is done. All I have to do is drag the rubber dam sheet on the other teeth on which holes are punched. Once that is done, you pass a floss so that the rubber dam sheets are well near the cervical area of the teeth. Once that has happened, put the widget on the last tooth on the opposite side so that it stays and it's stable. Make sure to invert the rubber dam from here. Do not put it on the nose. You should let the patient breathe, right? So invert the rubber dam from the top. That's one mistake a lot of candidates do, I think. And then you take the plastic filling instrument and invert the rubber dam at the cervical area of the teeth so that it's well inside. Make sure that there is no leakage. If you find a little bit, use that liquid rubber dam. And once you're done again, just upright the patient chair, do your hand hygiene and leave. So that's your rubber dam task. Scaling, their mannequin, they will only ask upon the lower jaw. Either it would be 4-3 and 4-6 or 3-3 and 3-7. Now in the scaling task, you don't have to take anything from the clean area. Curate. Now curate is something as a general practitioner you never get to use. We always do just the scaler thing. So subgingival scaling is what you should practice 3 or 4 times. You should learn how to hold the modified pen grasp. Make sure you're inserting the scaler like parallel to the tooth surface, not at an angle or something. And then the cutting edge is always towards the tooth. Don't make a mistake in that. Also pick up the proper curate. So first you have to remember the numbers of the curate. 1, 2, 3, 4, 5, 6 is for anteriors. So when they give 3, 3, there are many sets of subgingival curate kept. And they are very smart. You know what they have done? They have kept many instruments and it's written there SCG subgingival, and there is another instrument which looks exactly like the curate. Numbers are also mentioned there, 1, 2, 3, 4, and 7, 8. Everything like the curate, but it's written REX. That is not subject level curate. So make sure that you read, spend a lot of time in reading the instrument. So pick up and keep in your mind when you're doing the canine. Okay, I'm doing a canine. Just just pick up curate 1 and 2. So 1 and 2. Forget everything. For anterior, just remember you have to pick up 1 and 2. So pick up 1 and 2 and make sure that it's written SCG, that is subject level curate. Scale the canine. That is done. Keep it back. Don't keep it back on the bracket table. Keep it back in the cassette which they have provided. Now, once you have done that, then you start with the molar. Now, molar will require two different curates. One is for mesial, one is for distal. Because in the scenario they have mentioned you have to scale the mesial distal surfaces. They have not mentioned buccal lingual surface. So, if they mention buccal lingual surface, then you have to pick that up. So, in the mesial distal, then it becomes 11, 12, and 13, 14. 11, 12 for mesial and 13, 14 for the distal. So make sure whatever you're picking up is matching with what you want to do. A lot of numberings to be remembered, the areas, how you hold, so that will come by practice only. So that is subgingival. Just show the strokes to them. They require short strokes, not long strokes, short strokes. And make sure when you're doing it, you don't accidentally lift up the jaw, so be very gentle with it. Also, one more thing that you can do is just before starting, there is a periodontal probe kept. You can take the periodontal probe and just do walking around the tooth on which you're going to do the scaling. You may just get extra points. Like I did that. I had subgingival scaling in my exam. X-ray. I had also had X-ray in the exam. Now, X-ray is something which you practice like 3-4 times and you'll be good with it. If you have those cur holders. So in the exam, you have cur holders, rin holders, and there is that slip also of the plastic with which you take bite wing. But I wasn't aware of it or have ever used it. So I prefer the cur holders and I had practiced with that. So scenarios that can come is patient is having wake pain on the right side, which was my scenario. So what will you do? Bite wing. Wake pain, you don't know the teeth, and it's just the right side, you don't know which tooth it is. So first thing you'll do according to the guidelines is bite wing. Next scenario that can come is the patient is having pain in 2-6 and take IOPA. They will mention take IOPA. So then you have to specifically take IOPA. Third scenario is patient had trauma in the upper jaw. 1-1, yeah. Patient had trauma in 1-1. So in this scenario, you will take an occlusal and you will take a periapical for the anterior. Now for the posterior, adult IOPA and bite wing, you take the phlegm size 2. And for the anterior, you take the size 1. Okay. So learn how to assemble the rings. Like I really cannot explain that. You have to learn by yourself. Now there is a screw at the end of the mannequin, so you can open the jaw. The jaw is already opened actually. So when you're doing a bite wing, you place the bite wing and you close. Now when you're doing a bite wing X-ray, you have to lift up the tongue. Okay, take a mouth mirror and just scoop it out. The tongue will get lifted. Then only you can place the bite wing properly. Make sure your tube is proper. And she will see my all examiners were female for the skilled oscees. So she will come and see how you have position, and then she will ask you, show me the exposure. So you are supposed to go outside the room, and there is this exposure tab which is made. So you tell her that I'll be shooting. She didn't let me shoot. We did not shoot the film, but she told me which buttons would you would press. So I told her that I would press adult and then bite wing. So like this. Now if you had anterior, then you would say adult and periapical. And if you had occlusal, then adult and occlusal. If you had a child, so read the age properly, then you would say child and periapical. So read the question properly. These are the scenarios. Then you come to pit and fissure. Pit and fissure is the most time-consuming task. It's a very easy task, but it's a very time-consuming task, and you have to take a lot of things from the clean area as well. So practice a lot because you literally have to sit and count 20 seconds with that curing light. They don't have a flash cure light. We have a flash cure light in our clinic. It cures in 5 seconds. But in the exam, you are supposed to show. So you have to carry etchant, pit and fissure, and the bonding. And no, there's no bonding. There's just etching and pit and fissure. There is no bonding. Yeah. So yeah, you have to do that. Make sure your sealant is not overflowing. Make sure it's not in excess, and also make sure that it's covering the buccal groove in the molars and the palatal groove in the upper part. Also, make sure that you're doing on the right quadrant. Don't get stressed out in the exam, and instead of the third quadrant, work on the fourth quadrant. So make sure that you do all this. So practice again and again. Then come to extraction. Extraction, I believe, is the most simplest task. All because all they want to see is how you hold the forceps. That's all. So two scenarios only. One, you're extracting either 4/6 or 4/7, or you're extracting 2/6. Now in the 2/6, you're supposed to make sure that the beak, there's one beak which is flat, and there's one beak which is like this. You understand what I mean? And that has to go on the buccal side. So make sure you pick up the right forceps. Once you pick up the right forceps, you have to take the support properly, either for the mandible or the maxilla. Position your forceps and don't have the finger in between the arms. You are supposed to just hold it properly and then position. And then it's written very well in the question that once you are ready with the position, you are supposed to call the examiner to check. So read the question very properly. Once you have done that, the examiner will come and check how you have held the forceps, and then she will be like, okay. And after that, you definitely should wash your hands because you have done exo. So that's about extraction. Now coming to CPR and syncope, practice the scenario. So for CPR, you always follow the sequence of DRS, ABC. D is for danger, remove the danger, that's the bracket table. R is for response, you will check the patient, are you responding? So read the name of the patient properly on the screen. And with that name only, you're like, are you okay? Are you okay? Like this, like literally shout and show on your face that it's an emergency. But you don't panic inside, it's a mannequin after all. But you show, but you don't panic in your head, okay? So there's no response, so the examiner is standing, but you are going to pretend that you have to do everything, and you're speaking to the patient, but you're actually addressing the examiner because he will be answering the questions that you will ask. So for the CPR, the biggest clue is that the mannequin would be lying on the floor. For the syncope, the patient is still on the chair, and they would have mentioned that the patient is still, you just gave some injection, and you just turned to do something else, or you went outside the room, and when you came back, the patient was like not responding. For the CPR, the mannequin is on the floor only, so it's a CPR case. That's how you distinguish between syncope and CPR. So then, yeah, you say send for help, DRS, S is for send for help. So you will say, please send for emergency, call 000 and call for a defibrillator. So the examiner will say there is no defibrillator. So you'll be like, okay, thank you for answering that. Then you say, then you pretend, then ABC, airway, you check the airway, you will lift the chin up, okay, and you will try to see the airway. So the examiner will say the airway is clear. Then you will say, then I'm looking for breathing, ABC, right? B is for breathing. I will look, feel, and watch for breathing, like that. So you will place your ear next to the patient's nose to hear the breathing. You will look at the chest if it's lifting up and down, and you'll try to feel the air. The examiner will say the patient's not breathing. Then you'll be like, I want to check the circulation. So you want to check the pulse. The moment the examiner says the pulse is absent, you'll say, then I'm starting the CPR. And then you do the CPR, 30 compressions to mouth breathe. You'll have to keep doing it until the examiner asks you to stop. Sometimes it goes for 4 rounds and it becomes exhausting, but you keep doing it. So when the examiner says, okay, the ambulance has arrived, then you'll be like, okay, then I will just leave it. And then the examiner will say, okay, maybe you're tired, so you can just go out and take a rest or something like that. Now, CPR and syncope are the only stations where you're not supposed to do any infection control because it's an emergency. So you drop everything and you just directly rush. And make sure you remove the bracket table away. Remove the danger away. That is very, very important. And in syncope, you have to fill an incident report because the patient will recover. The examiner will say, when you're doing all these things, you'll be making the patient lie in the trundle and burp position, that is the supine position. The patient will start to recover. So the examiner will be like, the patient has recovered. So you pretend talking to the patient, how are you feeling? Are you feeling better? And the examiner says, yes, I'm feeling better. So then explain the mannequin, but addressing it to the examiner that you had just fainted, we had an episode, has this happened to you before? It would be wise to get a check from your GP, and we have called one of your family members to come to pick you up. So you just rest here for a while until you feel all right, and I will just fill an incident report. So there is a paper and a pen kept. Go sit there and start writing that so and so patient had a fainting episode, and it was the first time or the second time we have referred to the GP. The patient's vitals are fine right now, and we had placed the patient in the supine position, etc., etc. So these are the skilled OSCE stations, and I've given you a gist. I don't have those mannequins where I can show you how to do X-ray and stuff. And anyways, all of you will be taking a course, and you should be taking a course for the skilled OSCE one day. Even I took for one day, yeah, paid like $900 for it. So yeah, you have to do it because otherwise you won't be confident, because you need to know the scenarios, you need to practice properly. So I hope this video helps, and yeah, thank you. Bye bye.